So good evening all. So we start is paper two. Paper two is surgery in general, and surgery in general include many topics like trauma, head injury, and also nutrition, orthopedic, GIT, vascular, urology, and the neurosurgery. So all the topic of surgery in simple way, because we call it surgery in general, and this is exam is for not postgraduate study, it is just inlet exam, so it is a basic knowledge in the surgery. Okay, I will start. First question is 28 years old man in the surgical intensive care unit. He suffered from flare chest injury several hour area and was intubated and ventilated. Of course, we know the indication of the intubation if the Glasgow scale is below 8. Over the past few minutes, he's become increasingly hypoxic and now need increased ventilation pressure. The trachea is shifted to the other side. So the clue here, the patient intubated, trachea shifted to other side. So trachea shifted to other side is indicate what? Dr. Lee, if you have an idea, what's this answer of this question? What it could be?
Tension pneumothorax.
Okay, so this is tension pneumothorax because of the trachea shifting. Of course, if this patient have cardiac tamponade, you can find congested neck vein. Both can be mimic each other, except in the cardiac tamponade we have congested neck vein. We have hypotension can occur also in tension pneumothorax and have muffled or weak heart sound. The next question, 28 years old man involved in RTA and sustained flare chest injury. On arrival to emergency department, he is hypotensive. On examination, they have elevated or increased jugular venous pressure and auscultation of the heart reveal muffled, mean weak heart sound. So here it is clear that the patient has the triad, what we call the PICS triad, which is increased jugular venous pressure or congested neck vein, muffled or weak heart sound, and hypotension. So this is the typical OPEX triad, which is diagnostic for cardiac tamponade. Okay. Of course, the cardiac tamponade, the management is pericardiocentesis and done injury urgent before the blood is clotted. Third question is 27 years old man involved in RTA. He is seen in emergency department with chest pain. Clinical examination is essentially unremarkable, and he discharged. He subsequently is found dead at home. On review previous chest X-ray, there is widening of mediastinum. What is most likely underlying injury? So, of course, widening of mediastinum, if we look to it, especially in acceleration, deceleration trauma, it is indicate what? So anyone can know what is this indicate?
Traumatic aortic disruption.
Okay, so it's traumatic aortic disruptions. Also, it is not common, but it's common with high velocity or acceleration, deceleration trauma. So it is traumatic aortic disruption. This is a picture. Nowadays in exam, we put a picture. So you can find the picture like this. So it is a widening of mediastinum, sometimes bigger than that. Okay, next question is 22 years old man is brought to the emergency department and he was found trapped under building collapse, lying unconscious on his right arm. His right arm is mottled in color. Mottled mean like half dark and red color, swelling, and his hand is stiff and no sensation. Loss of sensation, of course, and the loss of movement is the end stage or the last stage of the ischemia in the limb. What substance is here? He don't ask about the scenario. He asked about what substance is most likely present in the urine in increased quantity. He need to ask you in crush syndrome or crush injury or collapse building or what we call this sometimes rhabdomyolysis. So what you found in the kidney and can cause acute kidney injury. So what it could be? What is the answer here? Anyone?
C.
C. So it is myoglobin, it is crush injury, and plenty of fluids. Okay, so we give the patient plenty of fluid to avoid this. So this is a case of crash injury, and we give the patient plenty of fluid to save the kidney. Sometimes we do something called hemoperfusion. It's some sort of dialysis. Next question, 23 years old man sustained severe facial fracture. Facial fracture means the facial bone, the bone of the skull fracture, and reconstruction is planned. What is the following investigation facilitate pre-operative planning? What you see, you can see this picture. This is skull picture, and you have a fracture. We called it Lefort fracture. It is grade 1, 2, 3. Grade 1 affect the maxilla, grade 2 up to the orbit and around the orbit, and the grade 3 is higher, including the lower part of orbit. So how to diagnose this? So what is the investigation, or what is the radiological investigation you can diagnose this Lefort fracture? Anyone have an idea?
D, computerized tomography of the head.
Yeah, CT of the head is a diagnostic for the fractures of the skull bone. Of course, in the mandible, only isolated fracture mandible, we have something done by the dentist. It's called panoramic X-ray. But panoramic X-ray only for the mandibular area. But to see the other bone of the skull, so you need X-ray, CT of the skull. It is important. After that, we have some question also related to trauma, but they ask you about Glasgow Coma Scale. Glasgow Coma Scale is very, very, very important. It is not tricky, but just remember, so it is important to know Glasgow Coma Scale. 20 years old man is hit over his head with a mallet on arrival in accident and emergency department. He opened his eye to pain and groan or incomprehensive sound. On application of painful stimuli to his hand, he extended his arm at the elbow. So if you take it one by one, so first he's open his eye to pain. So when you make a painful stimuli, he open his eye. So we consider it E2. Groan or incomprehensive sound, so the sound is not clear, so it is also V for
E2.
verbal 2. On application of painful stimuli to the hand, so again, it is his extent. So extension is M2. So this patient is E2, F2, M2. So the total is 6. So it is important to remember, again, this is a classical coma scale. We have I out of 4. We have verbal 5, and we have movement 6. Of course, if the patient open his eye normal, okay. To pressure is 2, to sound is 3, and spontaneous 4. None, so 1. None means that he's unable to open his eye. Okay, so good is 4, bad is 1. The same for verbal. He's oriented, he move 5. Confused 4. Word 3. Sound or unclear sound 2. None 1. In the movement, if the patient ask him, obey command, move your hand, move your finger, please obey, so 6. Localized, just if you have painful stimuli, so 5, normal flexion 4, abnormal flexion 3, extension 2, and none is 1. So it is important just to put this in front of you, because most of the question come like this. If you go to the next question, 20 years old man, after excessive alcohol intake, fall over and bang his head on arrive to emergency department. So we can start one by one. So first, open his eye in response to speech.
3.
Open his eye. Okay, to speech, so it is 3, correct. Can speak, although he's disoriented. So
Confused.
what is this?
4.
Can speak, 4, yes. And he obey motor command, so it is
6.
6. Okay, so this is 3, 4, 6. So it's 13. So the answer is 13. 1, 3. Another question, the same idea. A 20 years old man hit over his head with iron bar. On arrival to emergency department, he's opened his eye in response to pain. So it is
2.
E2. His obey verbal response in the form of groan and grants.
2.
So it is V
2.
2. So 2. On application of painful stimuli to his hand. So in painful stimuli, he flex the forearm away from the painful stimuli. So
3.
flexion is
3.
no, flexion can be 3, can be 4. If you go to back, so flexion can be 3, can be 4. Normal flexion or abnormal flexion, so can be 3, can be 4. Okay, so suppose it is here is 2 and 2, 2 and 2 and 3 or 4. So it is if 2, 2, 3, so it is 7. We don't have 7, so we have 7, yes. So it is 7, yes. So it is 7. So it is 3, so it is abnormal flexion. Okay. I just corrected here. Okay. All right. So again, Glasgow Coma Scale is very important. After that, we have different topic. 32 years old man involved in motorcycle accident, sustained closed unstable spiral tibial fracture. This is managed with an intramedullary nail. On return to the ward, he noticed that increased pain in the limb. And on examination, the limb is swollen, tender, with pain on passive stretch of the toe. Passive stretch means they make it forward. So passive stretch of the toe. So what is most likely diagnosis?
Compartment syndrome.
Yeah, so this is compartment syndrome. It is not DVT because DVT is a Hoffman sign. If you make movement or dorsiflexion, they have pain in the calf muscles. Of course, we know the compartment of the leg is 4 compartment because we have anterior, lateral, and the 2 posterior compartment. Okay, last question or in these topics is difficult. 33 years old lady developed thunderclap headache on the and collapse. CT scan shows that he developed subarachnoid hemorrhage. She is currently have no evidence of raised intracranial pressure. What is the following drug should be administered? So what is drug we can give to this patient if the patient
Manitol.
have say again?
Manitol.
No, mannitol can, but not in this condition. What we give it is nebudipine. Nebudipine is a calcium channel blocker. It reduces the cerebral vasospasm and improves outcome. It is admitted in most cases of the subarachnoid hemorrhage. Actually, mannitol, it is used in cerebral edema. You can use it later if the patient have cerebral edema. We use it in preeclampsia. We use it in cerebral edema with corticosteroid. But nebudipine is reduce the cerebral spasm, so improves the outcome or improves the circulation. Atenolol, of course, it is beta blocker in the for treatment of hypertension, not related to this condition, except if the patient have associating hypertension, and at this time we give him strong antihypertensive drug, not a beta blocker. So the answer here is nebudipine, which is one of the calcium channel blocker. Okay. This question is also a little tricky. 28 years old woman collapse and is found to be deeply comatose with Glasgow scale 3, very, very low. She admitted to the hospital, intubated, ventilated, a CT show extensive subarachnoid hemorrhage. Urinary catheter is inserted. What is the amount of urine would you expect it? So here also is have little trick. Okay, so what you expect, of course, in the shock debation, usually the urine is decreased and become concentrated. But like in any type of trauma, you can find the patient is hypotension, but in some head injury, you can find the patient, or most of the intracranial hemorrhage, you can find the patient hypertension. And in some cases of the intracranial hemorrhage or subarachnoid hemorrhage, you can find something different. Is anyone, what is the different here? This is patient have high urine or decreased urine? we make it per hour. You know that per hour you have 1 milli per kilogram body weight. So suppose you are 100 kilo, so the maximum is 100. So we have 30, 30, 60, 300, 300. Anyone have an idea? Okay, this patient will have increased urine, reverse to the expected, so the urine become increase and become diluted. This is, we called it, because in the extensive CNS insult, the result something mimic diabetes insipidus. You know, diabetic insipidus is effect or defect in the antidiuretic hormone. So the patient have some sort of diuresis and diluted urine. Some believe that it is hypothalamic effect directly, or something affect the hypothalamic pituitary connection. So in this condition, they have large volume of urine, diuresis, and the urine is diluted, not concentrated. In normal condition, in shock, without this particular head injury, the patient, of course, they have concentrated urine and less amount of urine. So decrease the amount of urine and they become concentrated. Okay. This is maybe somewhat not common, but this is the correct answer. Next question. 21 years old man involved in RTA, road traffic accident, after transient period of concussion. He found to have Glasgow scale 15, which is full by paramedics. On arrival to the hospital, he's monitoring inside room in the emergency department. With the next observed is noticed to have Glasgow scale. Suddenly drop becomes 3, dilated fixed pupil. So this patient, fully conscious, become disoriented or deteriorated. So what is the cause of this? What is the cause? Yes?
EDH.
What you mean? You mean
I mean the extradural hemorrhage.
no, it is transtentorial hematoma. It is herniation or transtentorial herniation. It is herniation of the brain stem, so can cause the patient deteriorated. This is why it is common in neglected case of the extradural. So if neglected extradural, not treated well, not treated from the beginning, so they have herniation of the brain and they can affect the respiratory center and the patient will die. So it is transtentorial herniation of the brainstem. Okay. Next question, 70 years old alcoholic man attend the emergency. On examination, no evidence of involvement in recent trauma. So the patient is old, no trauma. Skull X-ray failed to show any evidence of skull fracture. So no trauma, no skull fracture. He is admitted, and 12 hours following admission, he developed sudden onset of headache, become comatose, and died. So the patient is old, no trauma, and die. So most probably it is, of course, we know extradural must have a trauma, subdural with mild trauma. Most of the subdural must have a little trauma or mild trauma. Intraventricular hemorrhage occur in young. So this patient have subarachnoid hemorrhage. So subarachnoid hemorrhage is the cause of this patient, not due to trauma. Most probably it is due to hypertension or increased blood pressure. Next question, 62 years old lady is admitted to having falling down some stairs, sustained multiple rib fracture, 36 hours previously. So after 36 hours, so 1.5 days, on examinations, she confused, agitated, and the clinical evidence of lateralization signs. So they have hemorrhage. She deteriorated further and then died with no response to resuscitation. So 65 have fracture, have mild trauma or trauma, but it takes time to be presented and have localization. So what it would be? Of course, in old age, the common is subdural, but here we have two subdural. Because it is within 36 hours, so we still consider as acute subdural hematoma or hemorrhage. Usually, chronic subdural occur after 1 week, sometimes 2 weeks, and it is common. And the subdural hemorrhage is venous blood. Extradural is due to middle meningeal artery, so it is arterial blood. Subarachnoid can be, if it is some for perianeurysm, for example, so can be arterial blood, or sometimes it can be EV malformation. Okay, so the answer here, it is acute subdural hemorrhage. Okay. Last question in the brain hemorrhage and also tricky. A male infant born, so young baby, born at 28 weeks gestation by emergency cesarean section. He is taken to the theater for colostomy due imperforate anus. So you have many anomalies. He initially seemed to be progressive well. However, he began to develop decerebrated posture and becoming increasingly abundant. Which of the following is most likely underlying diagnosis? Actually, the pediatric, the neonatology or the doctor who care with the patient in the neonates, they found the common cause of the patient with immature baby. What's the common cause of death in this baby? Anyone have an idea? Which type of hemorrhage is common in these babies?
Intraventricular hemorrhage.
Yes, can. Okay. So of course it is we don't know exactly what is the cause, but they found that by PM or post-mortem, the most of the cases died due to intraventricular hemorrhage. So they found the early neonates deaths, especially in an incubator, if you have many anomalies, they found it is intraventricular hemorrhage. The exact cause till now we don't know. Of course, we know if the patient have perianeurysm or AV malformation, he can die from hemorrhage, but it is take a time. Sometimes it may be more than 20 years, more than 15 years. So become not a baby, it's become older. And of course, by exclusion, if you see the option here, extradural must have a trauma, and subdural usually in old age, and subarachnoid in AV malformation in old age, not old like in the adult, like
Adolescent.
10 to 20 or more, or sometimes can be 40 if the patient have hypertension. So the answer here is this patient develop intraventricular hemorrhage. Okay, so after that, we speak about the ASA scoring. ASA scoring is the American Society of the Anesthesiologist. Is a scoring to sterify the patient or classify the patient pre-op. Just we have 1, 2, 3, 4, 5. Maybe now they add 6. So 1 is normal, 2 is a patient with mild systematic disease like diabetes, hypertension. 3 has severe systematic disease like diabetes, hypertension, bronchial asthma not control. 4 is a patient with severe systematic disease in constant threat to the life. And 5, usually patient is morbid mean gasping or dying. So we have many options, like we start by first case. A 66 years old man admitted following a collapse while waiting for a bus. Clinical examination confirmed rupture abdominal aortic aneurysm. He is morbid, hypotensive. What is the following appropriate ASA scoring? So again, it is clear.
5.
It is, yes, it is 5. So it is terminal or dead or dying. 23 years old man have a 4 cm lipoma in his flank is due to have his removal as a day case. He's otherwise well. So he's well, fit, young.
1.
So it is 1. Correct. Third one, have many complications. 72 years old man due to undergo strangulated inguinal hernia. This is one risk. Repair, of course, hernioplasty or whatever as emergency procedure. He suffered from chronic obstructive pulmonary disease or chronic obstructive airway disease and has an exercise tolerance 10 yard. He's also have pitting edema in the thigh. So this patient have many comorbidity. Strangulated hernia, have edema. So it is like because of the
stage
edema,
4.
usually if the patient have heart or chest problem and bilateral, it means that it is not compensated or they have either renal or heart failure. So what this patient could be, which ASA?
4.
Okay, so this is ASA 4. Last question in trauma questions is a 45 years old man with tachycardia, feverish, hypotension on inotropic drugs. Which of the following condition most likely diagnosis? He just we have many type of shock as we mentioned before, but this patient have, of course, they have type of shock. We need to give him inotropic, so he is in shock, but he is feverish. So the clue here, they have a fever. Okay. So what is this type of shock?
Septic shock.
Septic shock. So this is clear. It is a septic shock. Okay. So again, as you see, most of the trauma questions is either, or what is important to know in the trauma is the Glasgow scale. It is important to know as a scoring for anesthesia. It is important to know tension pneumothorax with deviation of trachea to other side, and also to know PICS triad for cardiac tamponade, which is hypotension, muffled heart sound, and congested neck veins. So this is important topic, common in exam and come more frequent. After that, we have still in surgery in general. So we have some question, general question. Some of this question is related to nutrition status of the patient or what we call it surgical nutrition. And the other is related to skin disease and skin manifestation of some systematic disease common in England. So we start first by surgical nutrition item, I think. Okay, I just share the screen. Okay. Of course, one of the common question we ask about surgical nutrition is a post-operative nutrition. And we have this question, and it's common to come in exam. 72 years old man is due to undergo an oesophageectomy for malignancy. His BMI is very low, 17.5. Usually, BMI is about 25. What is the most appropriate immediate methods for nutrition post-operative? Immediate means that we need to feed the patient as early as possible. Historical, if the patient have something like oesophageectomy, we don't feed the patient and just give him TBN or total parenteral nutrition. Sometimes we start after a few days. But recently they found if the patient have no enteral feeding, the bacteria of the colon, bacteria of the intestine can have flare up and they can cause endotoxemic shock. So the new guideline is you feed the patient enteral feeding as early as possible. As we know that in esophagectomy, we remove part of esophagus and put the stomach up. So the stomach is in the chest, what's called it stomach pull-through or stomach tube. So gastroscopy or percutaneous end gastrostomy, what we call it PEG or PEG, is not suitable, is not applicable. So what is applicable here? We do something called feeding jejunostomy. So one of the steps nowadays, after you remove the part of esophagus, you put the stomach up in the chest as a stomach tube. You bring part of jejunum put it outside like we put colostomy or ileostomy, and connect it to the tube or put tube inside and become in the skin, and we called it feeding jejunostomy. So the answer here is feeding jejunostomy. This question is very common because nowadays jejunostomy as a step become one of the step of the excision or esophagectomy or removal part of esophagus. Just remember this. The second question or third question is related to if the patient is comatose or deeply comatose. If the patient have head injury and we know that he will improve as soon as possible, so is not in bad condition, so we can put nasogastric tube. But suppose is a patient in severe head injury and may be in coma for 1 year or few months. So nasogastric tube have a lot of complication. One of them is aspiration. So it is better to do gastrostomy or percutaneous endoscopic gastrostomy. So it is depend on how long we expected the patient to be in coma. So we start by second question. A 28 years old man is comatose from head injury and admitted to the neurosurgical intensive care unit. His recovery will and should be extubated soon because this patient in endotracheal tube. So which is the following is the most appropriate methods of nutrition? Anyone have an idea?
Nasogastric feeding tube.
Okay, so nasogastric feeding tube or rail tube. Nasogastric is a general term because the rail tube is the tube they have metal at the end. Maybe not common use now, but still we called it rail. But actually what we called it rail is not a rail. It is called the Levin tube, Levin. 43 years old man is recovering from laparoscopic assisted lower anterior resection with loop ileostomy. So this patient have ileostomy. So what is the most appropriate method of nutrition in the third day post-operative? So this patient have resection or anastomosis done in the colon, so left side. Ileostomy is in the right side. So if this patient take a food today, is affect anastomosis or not? Suppose after the operation and the patient can eat or drink, is affect anastomosis or not? Anyone have an idea?
I think it will affect the anastomosis.
No, because he don't affect anastomosis at all simply. What happened if you do the surgery, you do it in the left side, so anastomosis in the left side. Suppose, theoretically, if the patient eat after he recovered totally from anesthesia, what he eat is passed from the mouth, esophagus, stomach, duodenum, jejunum, and they come from ileum because they have ileostomy. So it's not affected the anastomosis. So the trick here in this question is this patient is appropriate nutrition to him. He can eat normal intake. He can eat normally. Any patient with a colostomy, the colostomy usually proximal, mean before the anastomosis. So why we make ileostomy or colostomy? Just to avoid effect or rupture or leakage or anastomotic leak. Because you know that we have a lot of the intestinal juice. Even if you don't eat, you have about 6 liters in your intestine come out like saliva, pancreatic, bile, and, gastric juice, small intestinal juice, all this. So this is why the anastomosis is done before the anastomosis or proximal to anastomosis. Will do ileostomy or colostomy, whatever. So this patient have ileostomy, so he can eat, he can drink, so normal oral diet. Of course, we start step by step, start by sips of water, and after that we can add some soft food or yogurt or milk, and step by step, not ask him to eat a lot suddenly. In the past, it is very important because in the past, they use a strong muscle relaxant. It can affect the intestine. Nowadays, but due to ERAS protocols and the new regulations, usually we don't give much muscle relaxant. Next question, a 23 years old man is recovering from appendectomy. For perforated appendix, he is now in ward. However, his urine output is decreased. and he has vomiting. What is the following intravenous fluid should initially administered pending analysis of his urea and electrolyte? Of course, if the patient have low urine output, you need to check the kidney function, urea and electrolyte, especially potassium. But till this happened, you need to give the patient fluid rich of potassium. So in this list, down 5 options, which fluid is rich of potassium?
Hartmann.
Yeah, Hartmann solution or Ringal lactate is rich of potassium. The other, like saline and the other, is just sodium chloride. If you don't have Ringer lactate or Hartmann, you can add 5 unit or 5 millimole of potassium chloride over the saline. Okay. Next question. 32 years old man presented with acute surgical unit with acute pancreatitis. He suddenly became dyspneic. Saturation, mean oxygen saturation become 89, which is low on air. Chest X-ray show bilateral pulmonary infiltration. Central venous pressure is 10 millimeter mercury. What is most likely diagnosed? So this patient have one of the complication of pancreatitis affect his lung. So what it could be?
ARDS.
Yes, so it is adult respiratory distress syndrome, and usually is one of the complication of acute pancreatitis. Actually, till now, we don't know why acute pancreatitis cause ARDS. Some claim that maybe increased lipase in circulation, have many theory, but till now we don't know the cause. All right, apart from this question related to surgical nutrition, we have some general question. General question like, for example, a 43-year-old man has a symptom of carcinoid syndrome. Carcinoid syndrome is occur in the tip of appendix, sometimes occur in the ileum due to increase or tumor, can be benign, can be malignant from the argentaphyl cell, which is responsible for secretion of serotonin. Okay. But here he don't ask about serotonin. He ask about which of the following is most effective therapeutic agent in to control the symptom. Okay, so also it's tricky, but what we control, what we use octreotide. Octreotide can use also in pancreatitis. It is somatostatin or synthetic somatostatin. But I just remind you that in the carcinoid tumor, increase serotonin. So the serotonin is increased. If we need to give something to control serotonin, we have an ondosterone, which is anti-serotonin also, we can use it. It is used as antiemetic. And also the carcinoid syndrome has tumor marker in the urine. It is the end product of serotonin, and we called it 5-hydroxyindole acidic acid or 5-HI. Okay, but here they ask about the therapeutic. So either octreotide is common to use to decrease the portal circulation. And also we can use ondosterone. In some countries, they called it Zofran is the treatment. If something is not clear, just open the mic and speak to me. Okay. Next question. 48 years old man in recovering in high dependency unit following major surgery. High dependency unit is something in England. It is in England, ICU is one patient to one nurse to one patient. In high dependency unit is one nurse to 3 to 4 patients. So the difference between ICU and high dependency is, of course, the type of the patient and the number of the nurses. ICU need a patient need ventilator, close monitoring, but high dependency is the patient after recover from intensive care, we can send it to high dependency unit or HDU. In Glasgow, in Scotland, they called it a step down unit. Step down means that the patient starts in ICU, go to step down unit, after that go to ward. Following major surgery, his preoperative medication include ACE inhibitor, angiotensin converting inhibitor, for blood pressure control. For the past 2 hours, he has oliguria with urine output 10 milli per hour. 10 milli per hour, it is very little, because it is supposed the normal is half to 1 milli per kilogram body weight per hour. So what is most appropriate management? So if the patient is oliguric and you need to test or to evaluate the condition, it is pre-renal, renal, post-renal, what is the cause of this oliguria? Of course, first you check the catheter is patent and all this. So what you will do after that, you check the catheter is okay, patent, not obstructed, in place, confirm the patient have a catheter. So what is the other test or other thing you need to do? What is the next step?
Stop
Anyone
the
have an
ACE.
idea?
Stop
Say
the ACE
again?
inhibitor. Stop the ACE inhibitor.
No, stop ACE inhibitor, okay, we can do it, but it is not the answer. We need to manage. We don't ask how to manage this patient.
Administer a fluid challenge.
Yeah, okay. So it is administer of the fluid challenge, which you give the patient about 200 saline and check the central line. It's supposed to be have a curve, so either become more increasing if the patient is hyperventilate, hyperinfusion, or become high and drop if the patient is hypoperfusion, or becoming steady if the patient is normal perfusion. So we call it fluid challenge test guided by central venous line. Of course, if the patient have wrong medication or high dose of medication, we stop it. Of course, it is important in the other scenarios, you look in to check if the patient take any nephrogenic drug like aminoglycoside or gentamicin, so you need to stop it. Next question, 56 years old lady presented with pathological fracture of proximal femur. Pathological fracture by definition is a fracture due to mild trauma. So usually can be due to nowadays due to osteoporosis or can due to secondaries. So which of the following primary site is most likely the source of the disease? So this is a lady, 56, have pathological fracture. So which tumor can cause pathological fracture, or which tumor can have bone metastasis?
Thyroid.
Anyone have an answer? Say again?
I think it's thyroid.
No. Thyroid, the only thyroid tumor give bone metastasis, it is follicular thyroid follicular carcinoma of the thyroid, and usually gives the secondaries in the skull. This is why in examination of the thyroid patient, you need to remove the scarf or remove the hijab if the patient wears something to cover her head. But the common tumor can cause in general, the common tumors cause bone secondaries in the human is breast and prostate. This is why we do bone scanning in all breast cancer and the bone scanning in all prostatic cancer. Okay, we don't do routine in thyroid. So this is the case of the breast cancer. Second, follicular thyroid carcinoma occur in age of 30, not 56. In thyroid carcinoma, we have papillary occur at age of 20, follicular occur about 30 to 40, and the other thyroid cancer like anaplastic medullary occur in older age. So in this scenario, it is breast cancer. Okay. 63 years old man undergoes a laparotomy and small bowel resection. 12-hour post-operative, he not have decreased urine output. Which hormone listed below is most likely responsible? So which hormone responsible for salt and water retention? Anyone have an answer?
ADH.
Yes, antidiuretic hormone. Of course, aldosterone can, but is not mentioned here. Antidiuretic hormone is responsible for salt and water retention. After that, we have many questions about plastic, but in exam, actually, skin or plastic is including many category in surgery. First, including wound and how to cover wound by flap and graft. Second, include some skin manifestation of some systematic disease like Crohn's disease or some inflammatory disease, because it's common in England. We call it skin manifestation of the medical disease. Second is how to take skin biopsy because of the skin tumor like basal cell carcinoma, malignant melanoma, squamous cell carcinoma is common. So this category is important. In exam, we have 4 questions in the skin disease, whatever it is, including the skin tumor, skin biopsy, or grafting, or skin manifestation of some of systematic disease. So this is very, very important. Actually, they have a picture in this type of question, and many of these diseases is not common in most of the country, especially Middle East and the Far East. Okay, so first to start by management of wound. Of course, management of wound, we have general idea. If the wound is more than 6 hours, it's not wise to close the wound because the rate of infection is very, very high. We just do a dressing and try to retail approximation, but we don't do suture of the skin after 6 hours. So the timing is important. Usually the inlet of the bullet, because the inlet of the bullet usually is have something called it dust or carbon stain, so it is rate of infection is high, so we don't close the inlet of bullet. Okay, this is general idea. Second, in the grafting, usually we don't put a graft except after healthy granulation tissue. So it's difficult to put in the bone and difficult to put in the tendons because it is less vascular. This is not important except in the chain of tibia, in the lower limb, because you know the skin of tibia, no, and in the lateral part or in some part in the upper middle and the proximal is just skin under over the bone, so no muscle in between. So the healing or grafting is not so good. So we can see one by one. Okay, so we can find here 63 years old male is gardening when his trap and land in the skis. He sustained deep laceration of his lateral side, which measure. So the wound is 3 by 7, penetrated down to the bone, but no fracture, is evident by X-ray. He presented to the hospital 9 hours after injury. He is type 2 diabetic mellitus. He's on prednisolone for rheumatic pain. What is the following most appropriate treatment? So this patient have diabetes and in cortisone therapy, and both diabetes and cortisone affect the healing power. So this is first. Second, this patient presented to us after 9 hours, so long time. So what is your suggestion? Anyone, what you suggest? This patient have many complications, healing will be not good, and came after 9 hours. So what you will do? You close the wound or you leave it for delayed closure?
Leave it for delayed closure.
Say again.
Leave it for delayed closure.
All right. Okay. So what we will do here, delay primary closure, simply because it is more than 6 hours. Of course, if you have bleeding, you stop bleeding by the therapy, you can compress something like that, irrigate the wound and all this, but after 6 hours, it's not wise to close the wound. Next, and it is tricky and have a lot of debate, so I write a reference for this. 71 years old lady trap over a full landing on her left shin. So again, shin of tibia, less blood supply. So sustain a large pre-tibial laceration. difficult to approximate. So this area, skin, no underneath muscle, difficult to approximate. Which of the following is the most appropriate management? I tell you why we have the debate. My opinion, or the correct answer, is delay split thickness grafting. Why delay? Because you give a time till the patient have little granulation tissue, so you can put split thickness graft or tertiary graft. Okay. In some version or in some books, they speak about what we called it free flaps or all this, and they can use gastrocnemius as a free flap. Actually, it is need a special highly center for vascular and for plastic surgery. So it is not practical. So immediate grafting is not practical. Free flap is not practical, need specialized centers. So the only logic is just delay split thickness graft. This is a reference, and we have, because of this is have a lot of debate, we have something called Duncan classification of peritibial injury. This is Duncan's is used by plastic surgeon. So he say in the front of the tibia, because have no muscle, if just a laceration, just clean and use a stir-strip. Stir-strip is some sort of the plaster used to approximate the edge, so it is not a suture. And if it is lacerated or flap with minimal hematoma, just clean, evacuated the hematoma, use a stir-strip, but avoid tension and do a dressing. If lacerated, moderate to severe hematoma, debridement of non-visual tissue and make a split thickness graft. But here, it must be delayed just to have a chance to have granulation tissue. If major reconstruction under general anesthesia in severe cases, this is what they use part of gastrocnemius muscle. You know, gastrocnemius is two parts, medial and lateral. Put it underneath the skin as a source of the blood supply. Okay, so what we mean here, it is just simple wound. So just wait for delay split thickness graft because this is edge is difficult to approximate. Okay, and this is the reference if you need it in the Annal of Royal College of Surgeons of England. It is 2017. This is just new, not much new. 2017 is about 7 years, but it is just to avoid this debate. Next question. If anyone have any comment or have another answer, can tell me. 73 years old lady presented with ulcer overlying her medial malleolus. Medial malleolus ulcer, what we call it gutter area, it is painless, has been present for 4 months. She has edema of the lower limb, ankle brachial pressure index, which is evaluation or estimated ischemia is 0.9, so it is good. The normal till 1. What's the following is the most appropriate management? So first, what does this patient have? So now this patient have ulcer in the medial malleolus, so it is venous ulcer. So how to treat the venous ulcer? First is just 4-layer, what we call it compression bandage or 4-layer bandage. The first layer usually is non-adherent plaster. We called it in Sofratol in some country. In some countries they called it Vaseline gauze. Is actually is not contain Vaseline, is contain antibiotic. But it is just some sort of the dressing or gauze soaked by antibiotic to become non-adherent, followed by many layers. So they usually we call it 4-layer compression bandage. Of course, now we have some stockings mimic this effect, but at least you put the first layer of the non-adherent gauze and a piece of cottons or dressing, and after that you can put the stocking, special stocking for varicose veins. After that, we have questions about how to take biopsy from the skin. We speak from surgical point of view. Okay, the problem usually is a tumor occur in the face. We have limited skin, so it's difficult to stretch the skin. And at the same time, you need to have safety margin. The minimal safety margin is 0.5 centimeter. So suppose you have a tumor, you don't know it is benign or malignant in the face. So it is better to take bunch of it, what we call it incision biopsy. So part of it just for rapid histopathology. So if it is a tumor, malignant tumor, you need to take a safety margin 0.5 centimeter, maybe sometimes more. But if this biopsy is just a benign lesion, so just remove with a minimal safety margin. So just to confirm. Skin biopsy, you can take a bunch, you can take incision. If a small skin lesion, you can, what we call it excision. So excision, you remove the whole tumor. Incision part of the tumor, but must be faster and know the result within a few days to complete your surgery. Or sometimes in some skin disease, we just put a slide like this, glass rod like this. We call it shave, like shave biopsy. So we have shave biopsy, we have punch biopsy, we have incision biopsy, we have excision biopsy, and all these can done in the skin lesion, especially skin tumor. Okay, so we can see one by one. For example, 83 years old lady presented with multiple patch of pigmented irregular superficial lesion over torso. It is important to know that usually tumor is not multiple. It's difficult to have malignant squamous cell carcinoma and multiple. Can the patient have one and after a few years have another one? Or can have recurrence? There is not bleed, but have become increasing itching. And usually tumor bleed in touch, but itching also can be with the tumor. So which of the following is the most appropriate management? This superficial, so we need to take biopsy just to see it is a benign or lesion. So superficial lesion is not an ulcer. Irregular and pigmented, so we're afraid to be melanomas. So what type of the biopsy we prefer to take? Anyone have an idea? Okay. Anyone have any suggestion?
Is it punch
Of
biopsy?
course. Say again?
Is it punch biopsy?
Say again, I don't clear, it is clear.
Is it punch biopsy? I'm not so sure. Yes.
No, it is shave biopsy.
Sorry.
We just make shaving for it. So we called it shave biopsy. It is excision biopsy in the single tumor, wide local in malignant tumor, thoracic biopsy in the swelling, not in the skin tumor, and bunch biopsy in big tumor. So you can see later. So the next one is more clear. 65-year-old man presented with long-standing 5 cm ulcerated area over the middle malleus. Again, in the lower limb or area of the lower limb, we don't have much skin to stretch. Not like thigh, not like abdomen. So in this 5 cm is a big tumor, by the way. So the most appropriate diagnosis here is difficult to take the whole the tumor because it is 5 cm. You need a safety margin maybe 1 cm around. So you remove a circle about 6 or 7 centimeter. So in this situation, you need to take part of the tumor, just send it for histopathology, and after that you have a result. So this part of the tumor, we called it punch biopsy. Punch means that you take in. Sometimes we called it incision, not excision. Excision means you remove. Wide excision, remove with safety margin. So this is called incision biopsy. or punch biopsy. And if you do it, you must have the result as soon as possible because irritation of the tumor can cause enlargement of the tumor. Next one, 23 years old lady presented with an itchy, bleeding with malignancy, itching with malignancy, pigmented lesion on her right side. Of course, the right side, you have enough skin. On the top of the previous hairy nevus, and you know that hairy nevus, if become itching and bleeding, it is sign of malignancy. So this is most probably or 100% is melanoma. Melanoma means malignancy. And usually melanoma can occur as a start or in some country occur over hairy nevus, and you found that increasing in size, bleeding in touch, and become itching. So this is tumor or this malignant lesion in the thigh. So if you excise it, so what you will do here? Anyone? What is the appropriate management?
See?
Yes,
Incisional
we excise
biopsy.
it with safety margin. So here we sure it is malignant. So excision with safety margin, usually safety margin minimal 0.5 centimeter, but if it is can be more, okay. Next question, I think I put a picture for it. 53 years old, white man presented with nodule in his chin, and he's concerned because his growth extremely rapid over the preceding week. On examination, they have swollen red dome shape with a central defect that contain keratinous type material. So we show you the picture. This is the picture of the lesion. So dome-like like the dome of church or mosque, and they have central area is not a necrosis, it is keratin. So like keratinized layer, like thick skin. And they give you option here. Squamous cell carcinoma, carcinoma in situ, basal, malignant, keratocarcinoma. So what it could be, if you remember the picture?
Is A, squamous cell carcinoma.
No, actually, it's not squamous cell carcinoma. This is typical keratocarcinoma. Because in the squamous cell carcinoma must be ulcerated, everted edge. Keratocarcinoma is common in England, and usually due to exposure to the sun. And it is dome-like, like everted. So it is not usually squamous cell carcinoma is ulcers. But this is dome-like, like everted area or high area, and not everted edge and central, not necrosis. They have central, what we called it, keratosis or keratin layer. So this is a typical of something called keratocarcinoma. By the way, squamous cell carcinoma of the cancer, of course, basal or malignant melanoma is pigmented. Bowen's disease or carcinoma in situ, it is a microscopic diagnosis, is not by naked eye. So you can, it is like dysplasia or carcinoma in situ. It is histopathology diagnosis, not macroscopic diagnosis.
Bali.
Say again?
Bali sa pangam.
Say again? Okay, so the answer here is keratocarcinoma. You agree, Doctor? I don't forget, what's your name?
Me. My name is Omar.
Omar. Okay,
Yeah.
Where are you from, Dr. Omar?
Malaysia.
Malaysia, you are welcome. Which hospital you are working?
Me now in Selayang.
All right, okay, you are
Selayang
welcome.
Hospital. Yeah, thank you.
Yes. Okay. Salamat pagi. Okay. All right. So, what we see now, it is keratocarcinoma. Okay. After that, also have a picture, but we just read it. So 68 years old Australian farmer. Of course, usually if the skin lesion, especially skin tumor, either common in Australian people, common in white races, not common in Middle East and the Far East, except if the patient have nephus and turn malignant. This is why they usually have a picture. 68 years old, Australian farmer presented with a skin lesion on the forehead. Of course, usually skin tumor in exposed area, but exposed area sometimes if the patient were short or something can be in the side. It has been presented for the past 6 months and has grown slightly in size during that time. On examination, ulcerated lesions, so they have ulcer usually with a cancer, with pearly white raised edge. Pearly white or everted edge is diagnostic for basal cell carcinoma. This is why we called it rodent ulcer. Measure 2 cm in diameter. Which one of the following is appropriate diagnosis? And he show you the picture. You can see the picture is become like ulcer at the end or healed ulcer at the end. And the central is necrotic tissue or depression, not keratin, not skin. So this is the typical of the basal cell carcinoma. Basal cell means that come from basal layer of the skin, squamous come from superficial layer, and melanoma come from melanocyte. Okay, next question. 34 years old gardener presented with a lesion affected the dorsum of his right hand. It has been present in the past 10 days and occur after has been bruising rose punch. A patient who is making gardening or have any foreign body irritation, on examination, his raised ulcerated lesion bleed easy on contact. And this is a picture. So sometimes if you have picked by pen, or especially in the gardening and have piece of the plant come inside you, they make this elevation. Anyone know what we call disease?
Pyogenic granuloma.
Yeah, correct, Bagus. So it is pyogenic granuloma. So this pyogenic granuloma occur if you are rotating by foreign plant or foreign material, usually common in the garden or people who is related to the agriculture's business. Next, 70 years old British lady presented with several skin lesions that describe as unsightly. On examination, she has several raised lesions with grazy surface located over the trunk, with scattered keratin plug located within them. So this is a picture. You commonly see in old European people, some pigmentation and little oily. This is, of course, not common in dark races or black races. And anyone know what we call disease lesion?
Seborrheic keratosis.
Yeah, it is seborrheic keratosis. It's just the skin manifestations occur in some old people, especially in white races. So it is a skin keratosis. By the way, epidermoid cyst is a sebaceous cyst. Next, 28 years old female presented with a small nodule located in the back of the neck. It is excised for cosmetic reason, and the histology report stated that the lesion consisted of sebum filled lesion surrounded by outer root sheet of hair follicle. So it is hair follicle structure, so contains sebum. So this is what we called it. I think I show you the picture. So this is in the back of the neck, can occur in the back or any area, have characteristic dark color. We called it punctum, and this is what we called it. Anyone have an idea?
Epidermoid cyst.
Epidermoid cyst. Okay, it is sebaceous cyst or epidermoid. Of course, epidermoid cyst is a correct name. Sebaceous cyst is a wrong name, but is commonly used because they found this epidermoid cyst is not arise from sebaceous gland. It is arise from structure around the hair follicle, including sebaceous gland. And of course, though it is cyst, but it's not cystic, because cyst means a cavity containing fluid, but sebaceous cyst is not contain fluid. So this is why it is not cystic, but still cyst, because the definition of cyst is cavity lining by epithelium. So it is epidermoid cyst, and it is not cystic, not contain fluid, it contain sebum. Next question. By the way, we're about to finish. We just have 10 questions, so don't be upset. 21 years old lady presented with a small nodule in the posterior aspect of the right cuff. It has been present at the site for the past 6 months after an insect bite. So this patient have insect bite. After this insect bite, they have this lesion for 6 months. Of course, 6 months, sure, it is not a malignant. The overlying skin is faint pigmented. So this is a picture. So the patient have insect bite or have some insect and have this pigmentation. This is difficult, but anyone know what we called it? Of course, it is not a cancer. It is not seborrheic keratosis because seborrheic keratosis is multiple. Capillary cavernous hemangioma is congenital. So this is called dermatofibroma. So it's occur in some, it is like little pigmentation due to foreign body or insect bite. Okay. Next question is easy because common in Malaysia. 22 years old man presented with infected sebaceous epidermoid cyst. The cyst itself is swollen, discharged pus, and have some surrounding erythema. What is the most appropriate surgery for infected cysts? Okay, so they have cyst infected. We know that if you have infected cyst, of course, you make incision and drain. In the infection or infected abscess or wound, we never close the wound. So must leave it open. So anyone know what is the option A, B, C, D, E? What is the option?
D.
Okay, so incision and drainage. In Malaysia, they prefer to call this suturization or something like that. No, the answer is C, not D. C, incision and drainage with excision of the cyst and the backing with the defect. What is incision and drainage with conservation? No, it is excision must excise, not conservation of the cyst. So the answer is C, what we call dissocialization. Maybe D is misleading because conservative of the cyst, we need to remove the cyst, the wall of the cyst by keratin to have keratage for it, just to avoid recurrence or come back. Okay. After that, the last topic we have is skin manifestation of the disease. And actually, most of this disease is European or British disease or common in Britain, not in our countries. So we can find, for example, the first one, 22 years old man, investigated for weight loss. He was diagnosed before as having gluten-sensitive enteropathy, what we call the celiac disease. Duodenal biopsy taken, investigation show total villus atrophy and lymphocyte infiltration. He has a skin lesion, a small itchy papule, and I show you the picture. This is the picture. So this patient have celiac disease, what we call it gluten sensitivity. And they have this nasty or bad skin lesion. Of course, it is common in patients have celiac disease. Celiac disease not common in most of the country, but some countries they have celiac disease. This is, anyone know it or difficult? Okay, this is called dermatitis herpetiformis. Dermatitis herpetiformis. I show you something maybe related, but is different, not this. 72 years old man investigated with loss, painless obstructive jaundice. So this patient most probably have malignancy like cancer, head or pancreas. On examination, deeply stained, cachexic, also have dark velvety lesion in his axilla, body fold and creases. So they have this skin lesion. This skin lesion, we called it, anyone know what is this called? If the patient has this dark color in axilla. One of these, which one?
Acanthosis.
Yeah, it is Acanthosis nigricans. This Acanthosis nigricans is one of the skin manifestation of malignancy. Of course, it is occur in white races and occur in in many cancer, not particular cancer. So this is called acanthosis nigricans, is one of the skin manifestation. 32 years old man with long-standing Crohn's disease. This question is important because Crohn's is common, is one of inflammatory bowel disease. Which one of the following skin disease are associating with this condition? Okay, so this is a picture. And this patient have Crohn's. And this lesion, we called it bioderma granulosum. So bioderma granulosum occur with Crohn's disease. What else? This is dermatitis herpetiformis occur with celiac disease. So celiac disease have this lesion, dermatitis herpetiformis, and Crohn's disease have bioderma granulosum. And this is pigmentation or acanthosis nigricans. Nigricans mean black, like negro. Acanthosis means something in the skin and occur in some tumor. Okay. I just have maybe 3 or 5 questions. 4 questions is about thyroid. Of course, thyroid come to you many times. So come to you in pathology as thyroid tumor, follicular thyroid, papillary thyroid carcinoma in age of 20, follicular at age of 30, anaplastic and medullary thyroid carcinoma. And also come to you in physiology if you ask about the tumor marker of medullary thyroid carcinoma, which is calcitonin. And also come to you in surgery in general when he asks you about thyrotoxicosis and hypothyroidism. So thyroid usually is important topic. Of course, important in anatomy, in physiology, in pathology, and in surgery. So from surgical point of view, we have many questions about thyroid. Also, because this MRCS exam is not only for surgeon, it is exam for general surgeon and also for ENT surgeon. So this is why you can find many questions about thyroid. All right, I just found 4 questions. After that, I finish. So the first question, 33 years old lady attend the clinic after 3 months history of palpitation and irritability. By the way, palpitation, of course, we learned that palpitation usually with hyperthyroidism or thyrotoxicosis, but actually it can happen also in hypothyroidism, so can happen in both, but common in hyper. Second notes, if we usually in exam will give you the values and the normal value, just to be easy. So the free T4 is 40, high. TSH is less than 0.1. So it is low. Free T3 25, so it is high. So this patient have high T3, T4, and low TSH. Paras hormone is within normal and is not related. So what is most likely diagnosis? So what it could be? Anyone? Easy question.
Hyperthyroidism.
Hyperthyroidism. So it is easy, just straightforward. It is hyperthyroidism or thyrotoxicosis. 52 years old woman presented with palpitation. She is found to have AF, atrial fibrillation. Blood result, free T4 is 30 picomole. I just back again because I don't need to repeat it. So T4 is 30. So T4 is 30 is high. TSH is less than 0.01 is low. So which one of the following is most likely diagnosis?
Thyrotoxicosis.
Yes, so it is the same. It is a case of this is a case of thyrotoxicosis. Yes, correct. Next question. 42 years old woman presented with a goiter. Goiter means enlargement of the thyroid gland. Can be benign, can be malignant, can be toxic, can be non-toxic, can be anything. Any enlargement of thyroid, we call it goiter. On examination, thyroid feel lumpy. And sometimes they call it tender. The blood result as TSH 12. TSH 12, if we back to the normal values, So TSH is normal till 4. So TSH is very high. T4 is 2. Back again, T4 is 2. T4 is still 25 is low. Antithyroid peroxidase is high. So the clue here is for antithyroid peroxidase enzyme. So it is different, little different than thyrotoxicosis and other. So what it could be? We have many options. So what it could be? Anyone? Antibodies, thyroid antibodies is high. So anti-thyroid antibodies is high usually in thyroiditis. We have many types of thyroiditis. He don't mention here except Hashimoto thyroiditis. So in thyroiditis, you can find two things. Sometimes the hormone is very high, sometimes it's low. So it is variable. But the thyroglobulin antibodies or anti-thyroglobulin peroxidase, one of them is high. So this is diagnostic for thyrotoxicosis. Of course, it's difficult to differentiate between many types of thyrotoxicosis because it needs histological or histopathology diagnosis. So usually, if they found the patient thyroid case with sometimes very high, sometimes very low, without treatment, have tender thyroid or tender lump in the thyroid, have thyroid antibodies or thyroid antiglobulin antibody or antithyroid peroxidase antibodies, so it is a straightforward thyroiditis. Hashimoto thyroiditis is dangerous because this Hashimoto thyroiditis, if not treated, can cause lymphoma or non-Hodgkin lymphoma of the thyroid. And this is why we don't consider lymphoma as primary thyroid tumor. Lymphoma occurs secondary to Hashimoto thyroiditis in the thyroid. Next question. 55 years old man in the intensive care unit for many months after open aortic surgery. This is common question. Patient admitted in ICU, whatever the cause. He maintained TBN, total parenteral nutrition. Clinically, he's athyroid, normal thyroid function, but his thyroid function test revealed a low TSH and a low T4. What is the following is most likely diagnosis. This is condition occur common in people after severe trauma or admission of the intensive care for long time or taking TBN because they have some sort of the hormonal disturbance. So what we call disease condition? Anyone have an idea?
Sick thyroid.
Yeah, it is sick euthyroid syndrome. So just because the ideal, we found TSH is high, T3, T4 is low, so it is hypothyroidism. The TSH is low and T4 or T3 is high, it is thyrotoxicosis. But if the patient all are low or all are within normal but low, so it is sick thyroid syndrome, usually a patient of long recumbency in bed, long period in the hospital, all this. Last question, simple question. 29 years old female undergoes subtotal thyroidectomy. 5 days post-operative, she will become erythematous, discharge pus. What is most likely organism? So it is just a simple wound infection. Of course, the thyroid is clean operation, so the rate of infection is 2 to 5%. So it's not much rate of infection, but can happen. If this happens, so what is a common organism? Think simple.
Staph aureus.
Yeah, so it is Staph aureus. Okay. Yes. All right. This is the last question. Just to stop sharing. Next time we will discuss. I will send you the question by tomorrow. We discuss GIT, gastrointestinal, which is the main topic in the surgery and the pediatric bleeding disorder, pediatric surgery, because these are important topic in surgery. Okay.